So, welcome everybody. I'd like to begin by acknowledging the traditional custodians of the region. Northern Queensland Primary Health Network acknowledges the Aboriginal and Torres Strait Islander peoples as Australia's First Nations peoples and the traditional custodians of this land. We respect their continued cultural and spiritual connection to country, waters, kin and community. We also pay our respects to their elders past, present and emerging as the custodians of knowledge and law. We're committed to making a valued contribution to the wellbeing of all Aboriginal and Torres Strait Islander peoples of Northern Queensland. And I'd just like now to hand over to Lori-Anne Trevi, who's on our COVID-19 response team and is based up in Cairns. Thanks, Lori-Anne.
Thanks, Kerry, and welcome everybody. I'd like to welcome our speakers today, Dr. Stephen Donoghue. We also have Annie Preston-Thomas, who is from our Cairns Public Health Office, and we have a couple of people from the Department of Health who've joined us, and thank you to them for joining us in their out of their busy day. It's Olwen McCoy and Lucy Coon. And so if you have any questions for the department, you're able to ask them during our session. And I also like to welcome our PHN staff and also welcome the RACF managers and facility managers, and thank you for coming in today. So, and we were having a little banter before about what's going on in Brisbane. So, so in light of the current evolving situation, regarding new cases in Queensland and the outbreaks in Victoria and New South Wales, we thought it was opportune for Dr. Donoghue to provide us with some information and also give you time to ask him any questions. So, Dr. Donoghue, I will hand it over to you. Thank you.
Thanks very much, Lori-Anne. Let me know if you can't hear me or something goes wrong with the slides. I'm going to run through a lot of material very quickly to try and provoke some thought and some questions. It's not directed at any places, of course, in particular. And if I say something interesting or there's something missing, then Annie's going to chip in for me as well. So I'm just going to go over to a set of slides. You should be able to see now a presentation called Paper Castles, because sometimes that's what I feel like, that we've got all of these independent castles that think they can keep the virus out just by controlling who goes in and out the door. And it's not as simple as that. And we're certainly all feeling a bit vulnerable because of what's going on in Melbourne. Last time I heard, there were 87 clusters associated with aged care facilities. So what we're really talking about today is we'll just review a few things about basic things about the virus, what's happening in Victoria, and then the different kinds of protection in layers, hygiene, infection control, and a lot of things around the staff and cooperation, and a few things around outbreak detection and responses, particularly for North Queensland, and how behaviour is really important in terms of protecting us, not just the physical infrastructure. So you can interrupt me or type a question and we'll come to that as soon as we get time. So the problem is, I think that a lot of you are feeling deluged. You know, the way to solve fire-prone paper castles is not necessarily to deluge them all with firefighting foam. So the regulators, the auditors and the authorities are on your back. There's a new aged care direction. There's this new definition of aged care facilities that are restricted. There are bucket loads of guidelines and posters and advice coming your way, and new procedures, forms, processes, plans, and of course all sorts of new rules about visitors that keep changing, vaccination requirements, reporting and staffing. You've got anxious families and staff, and sometimes I'm sure you're wondering whether you're required to open a hospital rather than a home for your residents. So a lot of this is just about how to keep up with it all and trying to see the wood for the trees among all of this traffic. Just a few basic things about the virus. Coronavirus is a pretty ordinary respiratory virus, and we know this from some of the other coughs and colds that are coronaviruses. They're enveloped viruses, they're easy to destroy, and we know a great deal about how they spread. Most of it is coughing and droplets. The whole thing about dried out droplets lingering in the air, we know that's rare, and we know that the rate of transmission is nowhere near airborne diseases like TB or measles. We know that also contaminated surfaces and therefore hands touching your face is important. And that's why all of this stuff about hand washing and hygiene and cleaning comes in. And we know more about the disease, how it's behaving. So we've got quite a variation in the incubation period, average 6 days up to 14. And that really means that any time in those couple of weeks after a potential exposure, somebody could come down with the illness and become infectious themselves. So the symptoms vary, but most of it is pretty ordinary stuff that looks like a cough or cold or a flu. But we all know that elderly people sometimes don't display normal symptoms, and they can just look a bit off, or perhaps mentally they're not as sharp as they were. They may not be in a position to tell us whether they've got respiratory symptoms. So that makes it hard. And not only that, but a lot of the infections are very mild, particularly in our staff, and some of them are asymptomatic, although we think probably those completely asymptomatic might be less infectious. The other thing to be aware of is that be careful about what's getting reported in the newspapers. A lot of it is what I call novelty bias. Things that are different or unusual get played up, and the ordinary way that the virus spreads is played down. So just be careful about that. All right, we know that the clinical picture is very ordinary. Fever, chills, cough, sore throat. It could be flu, it could be a cold, but it could also be coronavirus. And some people get nausea or diarrhea or muscle aches or tiredness. So it's very variable. The mild cases can last for a week or two. The severe cases can last for weeks, and then people can be recovering for months, or they may never recover. As happens with, of course, a proper dose of influenza. Some, particularly children, may not show symptoms at all, but we do think that children are less good at spreading this infection than adults, particularly young adults. Young adults are good at picking it up because they love socializing and going to pubs and bars and clubs and all of that sort of thing, and parties. Older people, those with chronic diseases, of course, are more at risk of hospitalization, of death, as we've seen. And that pneumonia or respiratory disease often happens in the second week of the illness. And as I've mentioned, some of them can get quite nasty long-term complications. So that's droplet spread. It's very similar to if you had a spray bottle with water in it. Most of it is going to be short distance. You can't really hit somebody across the other end of the room with a spray bottle. And that's why we keep talking about 1.5 meters as the ideal for social distancing, so that even if somebody does cough or sneeze, most of the infective material is going to fall down in that distance, and you're going to dramatically reduce, but not entirely eliminate, the spread of the virus. So infectious droplets, coughs, sneezes, even from singing or talking loud, but most of it is within a short distance. And remember that the paper mask or any kind of mask works better on the patient than it does on anyone else, because it can stop them coming out or slow down the velocity of that cough or that sneeze, which is propelling it in the air to somewhere else. Of course, if those droplets land on a surface and you touch that surface, it's pretty hard not to touch your face, and that's another way that you can get the disease. So again, lots of risks, and if you were to classify the risk, there are some factors around the patient and some about the route. The most infectious are people with upper respiratory tract symptoms. These are usually mild, and below that would be other symptoms or people denying respiratory symptoms or who are not symptomatic or in fact never symptomatic. That is unusual to get transmission from those. And the route, much more about droplets than dirty hands, and much more about dirty hands than airborne aerosols that go for longer distances. people are more infectious early in the disease, if they've had no recent negative tests, of course, they're at higher risk, or if they've got other epidemiological risk factors. And as I say, young adults are really good at socialising and mixing, and therefore they seem to be driving the outbreak, for example, in Victoria. And some people seem to spread the virus more than others. Partly that's behaviour and partly that's how much virus they're producing. So in terms of route, the high-risk areas are indoor areas, crowded areas, poor ventilation, problems or mistakes with PPE, and of course, vulnerable persons. I just want to talk a little bit about the incubation period. An incubation period from when you get exposed to the virus is a waiting period to see if you develop the disease for one maximum incubation period, which is 14 days. Now, just because you test somebody negative in the beginning of the incubation period, it doesn't mean that they couldn't get coronavirus tomorrow. All right, so a lot of our population think that they can clear themselves or come out of quarantine following a negative test, and that's not the case, of course. And so although we are now testing a lot of people who've been quarantined, it doesn't mean that the quarantine can be cut short. And the time periods around people's infectiousness and around people's disease or symptoms are not exactly the same. So we think that there's a period of about 48 hours between having symptoms and potentially being infectious, because they're shedding the virus. They don't yet know it, but if they were to cough and sneeze in particular, then it could spread to other people. And so when we do contact tracing, we actually take about 48 hours back. And that's why we've got to be a little bit careful about people who are not yet showing any symptoms. It doesn't necessarily mean that they're not infectious. And of course, people can become non-infectious well before the end of the symptoms. Sometimes the symptoms can go on for months. You might even be able to test them positive, but sometimes it's dead virus that you're actually testing for. So if you need expert help, ask public health about those things. All right, and of course the infectious period is not fixed. It's certainly not 14 days, and it varies from person to person. So start with the first day of symptoms, go back 2 days beforehand in terms of when they might have been infectious, and then clearing people who did have the disease involves getting negative tests, making sure it's been at least 10 days, and having a medical opinion. So again, some complexities about whether or not or when people are infectious. Now, this is just a model showing you what happens when everybody's moving around and how quickly lots of people can get sick at once before they end the illness and become immune. And that's the sharp, short outbreak that we want to stop, isn't it? So can you see the epidemic curve at the top there? Annie, I mustn't have said anything wrong. You've been rather quiet so far. But I love this diagram. It just shows
doing well so far, Stephen.
Oh, all right, Annie, keep watching. Now, I've got 2 diagrams now, and one of them is where you've actually distanced or quarantined some of the people, and you can see that the spread of the disease is very much slower and a lot easier to deal with because you don't have so many sick people at once. And that's really what we're aiming for. Even if we can't keep the disease completely out of Queensland or North Queensland, we can do a lot of things to slow this thing down, even to protect our nursing homes and our hospitals. Really important people understand the difference between quarantine and isolation. The word isolation is chucked around all over the place by other states and politicians, not very accurately. People who are contacts, who are not sick, in the waiting period are in quarantine. If they get sick, then they are in isolation. Isolation is an infection control word. So if they're potentially transmitting or, infectious, then they're in isolation. But somebody who's in a quarantine period, if they've tested negative, they may still have to go back and finish their quarantine because you might test them another week later and they're positive again. So just try and be very careful about that terminology. If we get it right, then we'll understand each other more and not make some mistakes. Now, this is another diagram showing just how quickly this disease can spread, about a week apart. But if you can contain some of those chains of transmission it can be a lot easier to manage. So I'll let that go through just once more. And that's what we're doing in public health and, of course, in infection control. All right, so a lot of people ask about immunity. We don't have final data on this question. We know that people do get better, so there must be some kind of immunity, but we don't quite know how long it lasts. My guess is that children do well with this infection because when they're very young, they've got a strong immune system. It's a bit like learning to ride a bike. At the moment, young children fall off bikes, but if we all had to learn to ride bikes at once today, the ones who'd be hurting themselves would be old people. Young kids would be doing really well, and those who fracture their skulls and their hips, it would be the elderly. And that's exactly what's happening here. Our whole generation haven't seen this virus before. We don't have any partial immunity, and that's why it's the elderly in particular who can get sick. But of course, anybody can fall off a bike and anybody can get severe disease from coronavirus. Now, these are the latest numbers from Victoria, and not only is the so-called second wave much bigger, but it's a different kind of patient. In the first wave in Queensland and all over Australia, that black colour is people who've been overseas or who are their contacts in blue, whereas the unknown or the unlinked community transmission is what's causing a whole lot of trouble now. That's dramatically harder to control, dramatically more difficult contact tracing and quarantining of contacts if you can find them. And so that's putting a huge strain on the public health services, and it means there's widespread coronavirus in the community, and that's getting reflected, of course, in outbreaks in aged care facilities. They're not immune to what's going on in the community. So a lot of this started with problems in the quarantine system in hotels, but also, as I say, community transmission is harder. There was some poor communications. If you don't explain restrictions and social distancing to people, then after a while, they're going to start ignoring it. And I think lots of people in the big cities are now ignoring social distancing or hygiene messages. Maybe they don't feel that they're at risk. And of course, now they're getting into long delays with their testing and their contact tracing and isolation. They did a survey and it showed that 90% of people who were unwell were not isolating themselves before they got a test. And even after tested, about half of them didn't go home and stay there. They might have gone on and done some other shopping. And so this is a real disaster in terms of human behaviour. Even if it wasn't a leak from a hotel, there just doesn't seem to be enough social distancing or enough restrictions on businesses to get this under control. And of course, that's big money talking about whether or not they should close the pubs and clubs and bars and other places where people gather indoors. They've had outbreaks not only in aged care, but in meat processing places, cold rooms, storerooms, high-rise flats, and lots of crowded workplaces like call centres. Again, the outbreaks have got to such an extent that maybe they haven't got the ability to move people out who are contacts and cases from aged care, which I think is a problem. We know from the cruise ships that if you leave outbreaks running in high-risk environments, they only get worse. And that certainly happens in many of the aged care outbreaks. We've seen also that about 10% of the known cases in Victoria are healthcare workers, which is very worrying. And we'll talk about how that might be happening. And yeah, they're now trying to get lots and lots of people contact traced and not necessarily by experts. And so mistakes are being made. We think that restrictions hard and early are probably just as important as having adequate contact tracing. And I mentioned that if you get the terminology wrong, you just confuse everybody and devalue the message. So quarantine and isolation, different things. This is a very interesting slide from England, but it shows that during the peak of their outbreak, the additional aged care deaths were much bigger than the known COVID deaths. So they were getting a lot of people dying indirectly from coronavirus. That excess mortality means bigger than last year. You know, they know how many deaths on average you get a week in nursing homes. and a lot of deaths that could be because they've missed out on health services or because of general chaos or because they had coronavirus and it was never diagnosed. So just be aware that not all of the deaths are directly attributable or tested as coronavirus in our aged care outbreaks. So I think the key message from me today is that you can't just lock the door and expect the coronavirus to keep out. You need multiple layers of protection. Entry, particularly nobody who has any symptoms coming to work or entering the building, being able to track and trace them. Make sure that you've got enhanced cleaning with a particular focus on places that people touch. Really putting in place systems and capability and making it easy for people to sanitize or wash their hands. Make sure that we are doing physical distancing rather than social distancing. And what we mean is it's really important to keep people socially connected, even if they're not physically connected, so that they can phone or video conference with their relatives or wave to them through the doors or something, so that people are not lonely and depressed or trying to get around those restrictions. We know that sunshine and fresh air is really important. It's very hard to get this virus outdoors. And so if you can move, particularly this time of year, move activities outdoors, then really think about how you can do that. And then there's been a great focus on people, particularly staff or contractors or hairdressers or physios or doctors, moving between aged care facilities and carrying coronavirus with them. You've really, really got to look very carefully at that. And they've actually brought in regulations and principles, and in Victoria, and Queensland is working on it too, about trying to reduce the amount of people working across facilities. And the key problem, of course, with casual or insecure workers is if they don't work, they don't get paid. And that's a built-in incentive not to take that little sore throat seriously. All right, we'll talk a little bit more about infection control and protective equipment, what sort of training, supplies, what you can do to conserve your equipment, and particularly detecting illness early, isolating them, testing them rapidly, and liaising with public health. I don't want to hear from you when you've had 3 or 4 cases. I want to hear from you when you've got 1 case that you're concerned about. So just ring us up and we'll work it through. And I'll talk about something called passive versus active measures. A lot of people think the word active is best. Active measures means that somebody has to think and remember in order to change their behavior. Doesn't work with humans. It's a bit like asking people to not eat chocolate when it's all over the house and all over the supermarket. But passive measures are where you change the environment to make it easier for people to do the right thing. So if there isn't chocolate in the house or in front of you, then it's a lot easier to resist or to do the right thing when it comes to infection control. So passive measures to maintain the behavior of your staff is incredibly important. Don't blame them. Don't just say they didn't do what they were told. It means that perhaps that you haven't set up a good system to make it easier for them. So I kind of laugh about the display that we see at the door of every facility. It's like a display cabinet. It's got posters and sanitizers and books for signing in. People very rapidly forget all of that, and they'll just march through if they get a chance, or they'll just scribble something. They kind of get used to it. So unless you've actually got people looking at them and ensuring that they do the right thing and making sure they're not sick, the whole thing will fail. All right, so that's what I'm saying. Passive measures, much more important than people actively having to remember to do all of those things and exclude themselves if they're sick. And then in terms of the plans, again, I've seen places that have got very large plans, very well-detailed written documents. They're only as good as their application. And when I'm reading those plans, I'm asking myself, now when I'm reading this, is this just a copy of some other plan, or has it been written for the here and now? Can I tell that I'm reading about this facility at this time and about COVID? Then I know I'm looking at a good plan. So let's just start with distancing and outdoor air. Most aged care facilities have got a lot of scope for social distancing, keeping different groups of people separate or running activity outdoor. If you haven't changed your routines, then it means the routines may be more important than your residents. I used to say this as a intern in a hospital. If there's anything you couldn't understand about how the hospital operated, just ask yourself, how does it suit the staff? So often staff habits get in the way of changing things, changing routines, so that maybe not everybody is eating in the same place at the same time. Maybe, you know, there are things you can do about how you run your centre that would actually be safer. So really think about if you haven't changed your routines, you might be missing something. Enhanced cleaning, improving hand hygiene is a whole system of safety. Infection control nurses can talk about this forever. Cleaning in terms of guidelines and products kind of misses the point, because almost any detergent will kill this virus. So it doesn't necessarily have to contain bleach. This is not a gastrovirus. It's a very fragile respiratory virus, and it doesn't have to have 99.999 written on the packet. Okay, so ordinary cleaning, but done well and done frequently and monitored, is more important than any kind of magical products. And remember, fresh air and sunshine, good ventilation, particularly this time of year, it's beautiful. And if you are concerned about a contaminated area or a room or equipment, just not using it for 48 hours or 24 hours will make a big difference to the survival of the virus. It's not very good at surviving on ordinary surfaces. Now, cleaning, again, the focus has to be on areas that people actually physically touch. There's no point cleaning the ceiling fan or the curtains at the top or the roof. That's not where it happens. So you don't need to wear a spacesuit, as in that picture. It's really about thoroughness, checking and scheduling. It's the systems, not individual behaviour that we want. Look, the big open secret is that the outbreaks in Victorian aged care are driven by staff. That's the open secret. Often these are young people, they're very sociable, they have multiple jobs, they have low skills, they are insecure because they think they won't be paid if they get sick. All right, that is the main problem. They generally ignore or perhaps even conceal their symptoms. They may have poor PPE and hygiene skills because they haven't necessarily been trained. We know that there are just not enough nurses that we can afford to have in aged care. And because they're really busy, they cut corners. In particular, even health workers in hospitals, we find that they've got really good precautions and PPE when they're facing the patients. But then back in the tea room, when they're all sitting together, they let their head down, they let their guard down, they're close to each other, they're mixing with people from all over the place, and probably that's where the disease is spreading among the health workers. Sick health workers spreading it to other health workers or other staff, not necessarily at the resident or patient interface. So be careful about that. Really look at how people are having tea or what they do when they're not in front of the resident or the patient. And ask yourself, are my staff going to be disadvantaged for doing the right thing? For example, losing seniority, losing leave, losing money. If so, then you don't have the system right. All right, infection control. Clearly, I can't talk to you forever about this, but remember that infection control is a risk-based science. It's not perfect. You're matching the hazards to the precautions. So we've got standard precautions, which we do all the time in terms of clean hands, clean environment, and waste disposal. Waste disposal for coronavirus is pretty low risk. I've never heard of anyone get it from doing waste disposal or cleaning. Contact, when you're touching people, requires contact precautions. When people are coughing or they've got respiratory symptoms, that's when you need droplet precautions, and that's a surgical mask and eye protection. And airborne, really that's only when you're doing airway or aerosol generating procedures in hospital, and it usually doesn't apply to aged care facilities. So there was a question already about how long can you wear a mask? It's a bit like how long is a piece of string. Masks stop working when they're wet because you're breathing around them, and they are not safe if they're contaminated. For example, people are continually touching them or putting them on their neck or adjusting them. So that's when they need to be disposed of and replaced. People need to be trained in how to put on and safely take off and dispose of PPE. And we're looking into whether there's any expired PPE that perhaps we could help you with so that you're conserving the PPE that you have. But it's really important to avoid waste. Don't allow people to just put them on out of habit without thinking about the actual scenario. And we are certainly not at the moment in a situation where people need to wear masks at all times because we don't have current community transmission, although I know they're re-looking at that for places in Melbourne and Sydney. Probably would be a good idea to raise the whole issue of cloth masks for when you're not client or resident or patient facing. That's perhaps something that you could get your volunteers or auxiliary or families interested in. Cloth masks probably don't work quite as well as the disposable surgical mask, but they do help. All right, and then of course, making sure you've got a good setup for distancing and measuring how well the cleaning is being done. So this is really about systems, not individuals. All right, similarly, in terms of temperature checking, unfortunately, the clinical criteria for potentially having COVID is 37.5, and many of you would know that that overlaps the normal range for human temperature. So these laser forward thermometers are not very accurate. If you've got somebody you think, oh, I can't let them in because they've got 37.5, just measure their temperature with a real thermometer that is accurate. You know, the ordinary thermometer. They're very easy to clean, doesn't take you very long, and they're dead accurate if you use them correctly. That's only part of that comprehensive screen. The picture I've got there with all the stop signs and the display is that there's a person there. That's the key part of the whole thing. Not the stop sign, not the sign-in book, not the hand sanitizer, the person who's asking, are you all right? Are you well? If not, don't come in here. All right, and just to be aware, there are fake products being sold, fake masks and sanitizers. Sanitizers really need to have 70 to 80% ethanol or isopropyl ethanol to meet specifications. All right, so we know that there is increased evidence now that masks help a bit. They certainly do not substitute for distancing or hygiene or hand sanitizing, and it's important not to get a false sense of security. But they will stop a certain amount of droplets, particularly coming out of people, but also going into people. Don't use masks with valves because they allow unfiltered air out, which wouldn't be very good if you were the case. So they're normally there for interactions with sick or potentially infectious persons. You've got to be trained not to touch them, to put them on and off properly. And as I say, reusable cloth masks are something that we're probably gradually introducing into the community. The advantage, of course, is that you're not using up frontline PPE and you're still getting a reasonable degree of protection. But they're not a panacea. They're certainly not going to stop the outbreak by themselves. But I think it really is time to start looking around. There are very nice specifications available, for example, from Vic Health, and it might be something that you could have your support community involved in. Now, I keep hammering around about cohorts. You've probably seen this before. The Roman army organised their soldiers into small groups that did not mix. And that was really important because if there was fear or panic or food poisoning or mutiny or some other disease, only one unit went down. The rest of the army was still in good condition. And by the way, they did not have soldiers who also fought for other countries like Egypt or Greece. So they didn't have agency staff in the Roman army, and that's why they conquered most of Europe and half of Asia. So cohorting means that you're grouping residents or patients with a certain number of staff who don't overlap with other areas or other groups. If you had an outbreak in that area, it's likely contained in that area or that group. All right, they never meet, not even in the tea room or the meeting room. So think about how you can organize that in your facility. The particular problem, of course, is the contractors and the podiatrist and the man who fixes the roof. You have to be particularly careful in those situations. Maybe get them to come to only one section on one day, or try and have only the one contractor who does roofs in your building, or just really try and reduce that mixing that you can't necessarily avoid. And remember that if we're in a big outbreak, it may not be possible to quarantine people out of the facility, and that's where cohorting again becomes incredibly important. And then finally, outbreak detection and response. It's unfortunate, you know, that we've copied a lot of our guidelines from the flu, because we kept saying, oh, look, they've got to have a flu-like illness. There's got to be 2 or 3 of them before you ring the public health unit, blah, blah, blah. Keep in touch with families, because they know when their mother is sick, and doctors and other staff. And even one of them, if you're concerned or you're wondering about testing them, give us a ring. We're very happy to take calls from a limited number of aged care facilities. Don't wait for a whole cluster before getting them tested. And remember that the symptoms may not be straightforward respiratory symptoms. Don't send it necessarily to a private lab up here in North Queensland with a 3-day turnaround time at the best of times. And at the moment, I think it's closer to a week. Send it to the local Queensland pathology who've got a lab on site. And if we know about that test, we can get it done almost the same day. So then you've got a fighting chance of containing any kind of import or staff who's sick or outbreak in the facility. Then you can immediately go into your plan, execute strict isolation, quarantine and cohorting and whatever restrictions that you haven't already got, because it seems that we're already in outbreak mode. Most of the plans have got very large outbreak control teams. We can't get bogged down with meetings and information demands, but certainly public health is right there, and we would be very keen to give you support from the start without necessarily lots of meetings. Generally, the response is to isolate everybody and test everybody, and then we kind of know where we are. And you might end up with a large number of staff who are quarantined at home, and you need a plan for how you're going to cope with a big blow to your staffing. And that's where you need to work with other aged care facilities. No one can do this alone. You've got to plan together about how you might be able to support each other in that situation. And of course, you've got a plan for maintaining communication with families. That was the big gripe in many situations in Sydney and Melbourne. In particular, I beg you, please not to use the word lockdown. I don't know what it means. Are we in lockdown before or after an incident? Are we talking about a prison or an aged care? Do you mean restrictions to your staff or your volunteers or your contractors or your residents or something else? You know, if you've got, you know, it's better to specify what you're talking about. And if there are unavoidable visits or people coming into the facility, ideally they're only seeing one person, or they're only coming on one day and not going to multiple aged care facilities. During an outbreak, there may be means whereby people can still maintain contact with their loved ones. And here we've got a picture of a visit that's taking place across a glass panel, probably with a microphone. If you've got that set up, then you're ahead of the game for when you've got a problem. And of course, working with other aged cares, because it's unlikely you'll all have an outbreak at the same time. So in order to do things, and again, this is not very clear in the national and state guidelines, you need room to move. And that's why I've got the bookshelf and the game of drafts there. You've got to have space to move. You've got to have vacant spaces. You've got to have some flexibility. If you're chockers and full in every way, it's really hard to find places to isolate sick persons or quarantine their contacts. So think carefully about how you can do that. The safest plan is to evacuate all cases, and in fact to have contacts who are not even sick quarantined somewhere else or even at home with their families. So I would not be raising barriers to families being able to take their residents home or go on leave from a nursing home if they feel that they can do it more safely where they are. And that really depends on the family, how safe that other place is. Yeah, but having places to put people is the key problem with this strategy. We know that if you keep outbreaks in place, they tend to get worse because you're just not set up like an infectious disease hospital. All right, so very quickly, I'm going to go through a scenario with you. Let's say that there was a case that was diagnosed at your aged care, had some early symptoms. You assessed them properly, you put them in their room. They were seen by several staff who were all in PPE. Unfortunately, you sent the pathology down to Brisbane through a private lab, and it took 3 days. They're still sick, the GP had to see them again, and then you find out that the person is positive. Public health are on their way, you go into outbreak mode, you've got the press on your doorstep, and the phones are going off the hook by worried families and other people trying to get information. So what are you going to do? I don't know whether anyone wants to talk about this, but this is the scenario that is quite likely, that you're all over social media, even before you've told everybody in the facility that you've got an outbreak. Anyone want to talk about how to handle that scenario? Or Annie, maybe I'll pick on you for that one.
Stephen, it's a really challenging scenario, and I wonder if there's anything that the aged care facilities can do preemptively as far as communicating with families now when nothing's happening, to just say, in the event that something does happen, you know, this may be the way that it will play out, but we will definitely, you know, we have our systems for communicating with families, and we will communicate just to provide some reassurance to families ahead of time. I think it's really challenging. I'd be interested to hear from people working in the facilities how they're going their approach.
It's Marianne here from Resthaven and Mackay. Not exactly the same scenario, but 2 days ago, I think, we had a gentleman who was really sick, seen by his GP, upper respiratory tract infection was diagnosed, antibiotics were commenced, but he was really sick. Anyway, we did the COVID testing because we needed to be sure. We assigned one staff member to look after him each shift and to wear full PPE. We actually communicated we have got email contact with probably 90% of our resident representatives, so we communicated with them as to exactly what was going on, and we rang the others that we didn't. He came back, the COVID case was negative, so this is not the same scenario, but we then had to communicate with all the families again, plus not to mention all the memos out to staff so they knew what was going on. What I think did become apparent is that we need to do more education with our staff on donning and doffing correctly. Yeah, but that's what we did. I think it's just communication, but obviously we didn't have a positive case, so it's different.
Yeah, excellent, Marianne. I'll just show you my next slide because it's about that. I don't know whether you've heard the expression get on the front foot, but if you're going to survive at the crease in a cricket game, you've really got to take a positive approach and be proactive. So particularly if you're going to be crucified on social media, don't wait for Facebook to put the story out there, or even for Queensland Health. By the way, Annie and I are gagged. You can quote us, but we can't just get on and talk to the media unless we've got permission from Brisbane. It's usually the Chief Health Officer who's busy with something else. So, you know, I would get out in front here and say, look, the system worked. We found a case and we're following our plan. Dr. Annie or Dr. Donoghue were very pleased and congratulated us on our response. In other words, something happens, but you make a feature of it. Yep. You front up, you talk to the media, you give out the facts very early, and you save yourself all the hysteria and the rumours and the people camping at your front door. If confidentiality was broken, you have to say, well, that wasn't done by us. All right. So if people's names are getting bandied about, you have to be quite clear that we didn't do that, which it usually isn't. It's usually some gossip among, among families or residents. And then for some reason, the media like to say that the place has been restricted for deep cleaning, as they deep clean the schools and they deep clean everywhere. Of course, we know this is ordinary cleaning, and a lot of other things are going on that are not about cleaning. In fact, it's contact tracing, it's precautions, it's executing our plans. And then you're doing quarantine and isolation in consultation with your public health unit. Get out there in front and hopefully, and particularly reporting up to your managers or your company and your board and your families, and then you can get on with the job and they'll be more confident that you know what you're doing. So this is my last slide, folks. Basically, you know, there are lots of problems that I know you're faced with. One of them is that you can be ordered into some very over-enthusiastic situations. Sometimes the company will ban you from taking people back when it's perfectly safe to do so. Sometimes, you know, there really are difficulties in terms of the rights of the workers and the residents and the families. And, you know, you need support and advice on those things. You're being pressurised to operate like hospitals even before we've got outbreaks here in North Queensland. And you really need to look carefully at conserving your PPE. And that's why I'm saying maybe the cloth masks are part of the solution. Allow people to wear those when they are not doing direct patient care, and at least you can keep the PPE for when it's needed. But the key thing is passive measures. Those that facilitate good behaviour are better than just saying, oh, we told them what to do and they didn't do it. You've got to have a system in place where your workers are enabled to do things correctly, whether it's attendance when unwell, or hand hygiene, or infection control, or, you know, fraternizing with each other when that's unnecessary. You've got to set up those systems. And ideally, in an outbreak, we would be evacuating and decanting, because they are very valuable strategies. And certainly in regional areas, we need to work together and we need to have plans for how that might work. The national and state plans keep changing. We will be helping you with resources whenever possible, unless we've got multiple outbreaks, then it might be difficult. But sharing with each other, I think, would be another strategy. So that's it from me. I'm open to comments and suggestions. Annie, anything else from you?
Yeah, just one thing to add, Stephen. I'll put my camera on. Okay. One thing to add from here is that we've been working a lot also with the older people's outreach team from the hospital. And one of the things that they've been working on this is for the Cairns urban region, is their ability to be able to go to an aged care facility when, if required, to provide medical review for patients. And so decanting, I think, you know, that's not necessarily a definite for here. I think we will continue to watch and learn from Victoria and other places, but at this stage, we're hoping that there's going to be the ability, and, you know, taking into account what the wishes of the resident and their family and the capacity of the facility itself, where possible, we're hoping that people will be able to remain in their home.
Yeah, that's right, Annie. I mean, people need to plan to be able to remain in place, but ideally we would at least be removing the known cases to hospital in the first instance. But even the aged care support teams, I know they have different names in different places. They also have to think about their own infection control, because they move between facilities. So they're also looking really carefully at that stuff. It's an important point. So maybe if we could just open that up and talk to people about what their plans involved in terms of moving people out or remaining in place in the event of an outbreak.
I have a question in relation to renal dialysis patients that are going to be coming and going.
Go on.
Sorry, renal dialysis patients that are going to be coming and going from your facility in potentially when you have an outbreak. And I think for us, that's a bit of a concern, because most facilities, once they're told that they need to, I know you don't like the expression, but lock down, would be not terribly keen to have those patients coming and going.
Yeah, that's a really important point, Annie. Thanks for bringing that up. So you have not only renal patients, but people with immune suppression, for example, cancer treatment, who are highly vulnerable. And potentially, if they're moving between hospitals and back to aged care, there is the potential for spread. And that would all depend, of course, on how well the infection control is going in the dialysis or the oncology unit. If they didn't have any cases and they had no breaches, then there wouldn't be any problem bringing them back. But it works in both ways. If there was an outbreak at the aged care or an outbreak at the hospital, we would have to be isolating those persons in a way that we're not spreading it from one institution to another. It's a very tricky group, I agree.
Marianne, you had a question that came through.
Yeah, I was just wondering, I've seen them advertised on the TV, which I suppose is my first mistake, but those bombs that aerate something into the air that are supposed to be good for sanitising, credible or not credible?
Not credible. You know, at the beginning of the outbreak in China, they had people with trucks blowing this stuff into the air and spraying things, wearing spacesuits. I've never been able to work out what it is that they're spraying. Do you know, Annie? Can't hear you, Annie.
No, but they might have been lifting any coronavirus that was sort of lying on the.
Yeah, it's all a bit of theatre, unfortunately, Marianne. But no, just stick to ordinary known processes. This is not a special virus in terms of cleaning, not at all.
Yeah.
Good question.
I was interested in your comment that any sort of detergent is good enough. I mean, obviously that's apart from the sanitising hand gel, but so as long as it's soap and water, we're doing the right thing.
Oh, absolutely. Look, there are products that are specific and there are specifications that you have to follow, but a lot of it is mumbo jumbo. This thing is really easy to get rid of, and just doing the cleaning and doing it thoroughly is going to be more important than the brand, you know, the special product, or certainly don't go beyond what your already trusted products are.
So can I ask, what is the term a deep clean? What's that?
I don't know. This is why I'm saying the press love to use this expression, but it's just ordinary cleaning, doing it well, you know? Yeah, it's not like you can get coronavirus out of the building. It's in people. So, yeah, it's a really funny how this comes across in the press.
May I suggest, Sister Pauline, Marianne, you mentioned about the probably thing that you have to deal with staff is more donning and doffing. When it all started in March, we had all staff doing the training, donning and doffing. But the training actually consisted of watching a video and then, you know, that was it. But what we did over the last 3 or 4 months, whatever it may be, every now and then we'll take the kid to a group of staff and they actually do the donning and doffing, because watching something and doing it, it's sort of two different things. And probably you're right, that's probably the worst thing that people will get infected from.
That's right. And remember that they can get it from each other if they're not thinking about what happens when they're not dealing with residents. Okay, so health workers or aged care workers have infected each other while having tea or in the back office or outside or whatever. So it's not just the residents that you've got to be careful about. In fact, a couple of people in the comments, Lorianne, I can see that they've mentioned that they have put aside places where they could keep people who are potentially infectious or need to be quarantined. That's excellent. I'm really glad that you know, particularly places that have got empty rooms or empty beds, planning how you could profit from that ability. That's going to be really important in the event of an outbreak. So congratulations to those people too.
Dr. Donoghue, there was another question there from BN, is it? For the staff allocated to work with residents with positive results, how are they quarantined from their own family members after work?
Yeah, look, this is a really difficult question because clearly, you know, that person, particularly if they're not trained well in PPE, is taking a risk. Ideally, we've got people who are very well trained, and people have made arrangements for staff who are doing that one-on-one or that quarantined work to live separately from their families or even in a room at the facility. So I've heard stories, for example, in hospital wards where the staff actually live with the patients while they've got them there. They're staying somewhere in or near the ward or that section. So yeah, if you've got dedicated staff who are willing to do that, just make sure that they're really well trained to protect them and probably test them, you know, on any kind of indication that they could be sick. Breaches of PPE or actual contacts, those people may have to be quarantined. But there may be, you know, you could talk with us about those arrangements. It's sometimes a very, very useful way of protecting other staff and other residents.
There's another, thank you, Dr. Donoghue. There was another one from Fiona. We're planning setting up an infection ward for positive tested cases. So, yeah.
Yeah, and then Fiona's put something here about there are staff who've put their hand up for doing longer shifts in order to manage those things. I don't know what the industrial awards say about all of this, but clearly if you've got a good relationship with your staff and you've got a plan, that's going to be really, really important. And just to emphasise that you've all got to also plan for a situation where several of your staff may be quarantined. Staff can get this virus out in the community. Ideally, they haven't come to work while infectious, but you might end up with quite a few staff under quarantine, and then you need to work together, particularly with other aged care facilities, about how you might be able to support each other, how you may be able to keep functioning. I know that the hospital services have some kind of plan for supporting aged care, but of course that it may be limited. Annie, do you want to talk about any of that in Far North Queensland and Cairns?
Not really anything to add beyond that. I mean, I think it's going to be challenging in, you know, in the event that it occurs, and I think we've certainly had a few conversations about in the event that the aged care facility is having trouble with getting enough staff, whether the hospital and health service can provide any support staff. We've certainly talked through that, but I understand it's going to be an ongoing challenge.
Yeah, and there's another question there from Jenny about accessing infection control experts. Of course, every aged care facility should have somebody who takes care of infection control and has some expertise. But if you need support from hospital infection control teams or technical advice, that's always available. But whether it would be a full-time deployment would be much more difficult. So advice, yes, but providing experts, probably not. But again, you know, talk to us about that. So here in Townsville, I know we've got a thing called the Health Functional Working Group. It's a meeting tomorrow, which includes most of our aged care facilities. Probably these questions are going to come up. So it's good that we've had the session today. I put up a lot of stuff today that was just to get you thinking and planning. Obviously, we can't go through all of the aspects, and there's an enormous body of literature and plans and whatever. But really, it's about staying in contact with each other and talking with your public health unit. We're really keen to support you as far as possible to prevent outbreaks, but to be ready when they occur. Lorianne, I think we might have come to the end of the questions.
Yeah, I've got Olwen and Lucy from the Department of Health on there. Is there anything that you'd like to ask or answer?
Yeah, good afternoon. This is Lucy Keane here. First of all, I just wanted to thank Dr. Donoghue for doing such a wonderful overview. That was a really interesting update, and I'm sure it was very informative and helpful for all the providers listening in today. Aside from that, I think from the departmental view, there's probably not too much new to update other than, and I'm sure you're probably all across this already, but we've obviously had that new aged care direction number 8, which came into play yesterday. So just sort of flagging that with everyone and just noticing, I suppose, just identifying as well that those aged care facilities in the Metro South and some of the neighbouring suburbs in West Moreton region have had their, I suppose, their protection measures increased. So all that information is on the Queensland Health website. So strongly recommend you have a look at that.
Thank you, Lucy. Gavin, you wanted to say something there?
No, I think I'm just probably backing up other sentiments. I've worked with Stephen many years ago, and it's he's always a fond of knowledge, and enjoyed working with him way back when, and it's just really great to have him and the crew up in Cairns as well. I worked with Annie and Carly up there, and so yes, good to see you all. And from a communications perspective, I suppose just keep referring people to the NQPHM website. We do have an aged care section within our healthcare providers page. So it's obviously the latest aged care direction will go on there, and other bits of information as we receive it. So yeah, please keep checking the site. If there's anything that you think is missing or you'd like to see, just email us at hello@nqphn.com.au and we will action your request. But yeah, thanks from myself for all your support regarding communications. And yeah, thanks to Stephen and Annie and the team at Tropical Public Health.
Stephen, thank you as well. It's Al here. I really appreciate all the effort you've gone to over the last few months. You know, all of the webinars you've been doing, they've been incredibly useful. So we really appreciate that. And thank you everybody who was online today. Really appreciate you coming together and you know, working together. Annie and Carly, it's nice to see you in Cairns. I don't get to see enough of you. But I just wanted to say, Stephen, thank you. We really do appreciate all of the effort, and Michael as well. Michael's, you know, very ably assisted you over the last few months, so thank you for that as well. And Annie, also you and the team there for assisting us with, I think, numerous things within aged care up here. So we appreciate all of your input and advice as well. I just second Gavin's comments, so thank you.
Thanks, Al. There are a number of people that have phoned in. Could I ask you to email me with the organisation that you're from, please, so that if we do have another session like this, what we probably will, that we don't leave you off the list, okay? So could I please ask you just to email me with your organisation? And is there anything else?
I just have one comment to make. It's Sister Pauline from Francis of Assisi. We had an outbreak management committee meeting like last week or early this week, I can't remember now. But what we sort of decided at that meeting, because we know that relatives are going to panic if they hear that there is an outbreak in a facility. So we sent a letter now to say this is what we will be doing. So in that letter we included, if a person is positive, we will phone that person to tell that family member to tell them that their loved one is COVID positive. With the others, we said you'll receive an email to say that this is what's happening at Francis of Assisi home. Your family member is fine. We'll continue to do our best to protect them. So, you know, you pre-warn them if something is going to happen, they're going to hear it from us that their loved one is positive. And the other things that we prepared, so we prepared a letter for the GPs We prepared a letter for families to send, and we also prepared what we should tell the media. And Dr. Stephen, what you said was excellent. We didn't think of that, so thank you very much for that. It's just, I suppose, a forewarning because people will panic.
Thank you.
Thank you, Sister Pauline. Is there anything else?
Hey, it's Annie from Good Shepherd. I think people panic because the experience in Victoria and in Brisbane has been, your dad's okay, oh, he's dead. That's a really ugly communication strategy that's happened in some of those places. And I don't know if that's because the facility has lost control of the residents because they've got teams coming in, and that's the problem, or whether it's because the facility hasn't communicated. But either way, that's one of the really big risks for us, is not having that direct and immediate communication that's accurate.
That's right. So communications is part of the outbreak management. It's not separate. Yep.
Okay, Kerry, thank you, everybody. Dr. Donoghue, thank you so much for taking the time to dial in and provide us with that information. And Annie, thank you. And I'll catch up with you next week. Kerry, I'll hand it back to you.
Thanks, Lorianne. I have recorded this session, so once it's the link has come back to me, I'll arrange for it to be posted on the NQPHN website for future reference. Thanks, everybody, and I'll talk to you again soon. Bye.
Thank you. Bye.
Thank you, everyone.